Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Hello dear students. I am warm welcoming in our surgery lecture number 5, that is the perforated peptic ulcer and chronic stenosis. In this lecture, we will see the acute perforation, subacute perforation and chronic stenosis. First is the perforated peptic ulcer. Men are more affected than women. The ratio is 12:1, means 12 men are affected where the only one woman is affected by the perforated peptic ulcer. Now the pathology. First reason is the acute perforation, stage of peritonism, acid peptic juices, bile and pancreatic juices come out into the peritoneal cavity, peritoneal irritation, and stage second is stage of reaction where there is a chemical injury to burn of the peritoneum. Peritoneum reacts secreting peritoneal fluid copiously, gives relief of pain for the short time. This stage lasts for 3 to 6 hours. Stage 3 is stage of peritonitis. Diffuse bacterial peritonitis, acid secretion of the stomach is abolished. There is no acid barrier, so the bacterial invasion becomes easy. Starts within 12 hours of the perforation, after the perforation. Second is the subacute perforation, leaking peptic ulcers. Peritoneal cavity becomes contaminated by leakage, occurs due to the various factors, that is the small size of perforation, adhesions around the ulcer, emptying of stomach, plugging and sealing of opening by omentum. Third is the chronic perforation, when an ulcer perforates but the area is walled off and by adhesions and by viscera, or when a gastric ulcer perforates into the laser sac with a sealed omentum foramen, a chronic abscess may form easily present within abdominal mass. Clinical features: primary stage or stage of peritonism, acute agonizing pain in epigastrium or right hypochondrium, may or may not vomiting, sign of dehydration, that is the tongue is dry, skin is lax, and temperature slightly subnormal, that is 95 to 96 degree of Fahrenheit. Pulse is increased, there is a tachycardia. On palpation, tenderness, board-like rigidity, rebound tenderness is characteristically present. On auscultation, abdomen is silent, there is definite absence of normal peristaltic sounds of intestine. On the rectal examination, will reveal the pelvic tenderness. Secondary stage or the stage of reaction, stage of illusion or delusion. Fire continues under the ashes, means worst stage of peritonitis is on the way. Pulse high, temperature gradually rises. For some period, in this stage, patient feels better because the fire continues under the ashes. For abdominal examination, what we found, that there is a abdominal distended, tenderness and rigidity, but the rigidity is less marked. No vowel sound is there. In third stage, tertiary stage or stage of peritonitis, diffuse peritonitis develops. Patient looks toxic, that is the typical facies hypocritica, with pallor, sweating, pinched face, anxious look. Extremities cold, vomiting is now frequent. Complaint of insatiable thirst, pulse very high, small and thready. Patient is in shock, respiration is shallow and rapid. Temperature shoots up. Per abdominal examination, gross distension, accumulation of gas and fluid is paralyzed intestine. On palpation, no longer board-like rigidity, but the muscle still guarded. Special investigations is to be done. Straight X-ray of abdomen, it shows the gas under the diaphragm in the right cupula of diaphragm. Aspiration of peritoneal cavity shows the bile stain fluid. X-ray following injection of 60 ml of 50% of gastrografin through Ryle's tube. Dye escapes through perforation to identify its exact site. Treatment, but this will be the risky. Treatment is surgery. Preoperative management, mandatory to resuscitate prior to operation, that is the rest and sedation, NBM and nil by mouth and Ryle's tube aspiration 1 hourly strictly. IV fluid started immediately. Blood investigations. For shock, if severe plasma expander, Dextran is to be given. Broad spectrum antibiotic should be given strictly by parenteral route. Catheterization, input output TPR temperature, pulse, respiration charting should be maintained. And surgery, simple suture operation is there. Peritoneal toilet or drainaging, lavaging should be mandatory. Definitive operation for perforation gastric ulcer, partial gastrectomy for bile road first, operation with end-to-end gastroduodenal anastomosis with vagotomy plus pyloroplasty. And for perforated duodenal ulcer, vagotomy and gygestomy, gastrojejunostomy plus pyloroplasty should be done. Laparoscopic closure of perforation, minimal invasive surgery has become the choice of the day nowadays. Pneumoperitoneum with carbon dioxide, telescope is inserted this in subumbilical part. Now the chronic stenosis, there are three types of stenosis as a complication of peptic ulcer. Pyloric stenosis, second is hourglass stomach and third is the teapot stomach. First, pyloric stenosis, not due to the ulcer of the pylorus of the stomach, but mostly due to the chronic cicatrization of chronic duodenal ulcer. Scar at the chronic duodenal contracts and gradually narrows the lumen of the pylorus. Clinical features, onset is slow and silent. Pain loses its definite relations with food. Sensation of fullness. Vomiting, classical symptom of the vomiting. Copious projectile and false vomiting is characteristic. Vomitus contains undigested food. Vomitus gives considerable relief. Periodicity is lost. Constipation is also complaint. Loss of weight. On examination, visible peristaltic wave passing from left to right. Suction, splash heard on shaking of the patient abdomen. On auscultation, percussion, the greater curvature delineated and stomach found grossly distended. Special investigations, gastric function test, low acid, absence of bile, copious amount of mucus due to chronic gastritis. Barium meal examination shows a large and low stomach presence of barium even after 6 hours. Management, due to continuous vomiting, massive loss of hydrochloramic alkalosis along with hypocalcemia. Gastric juices contains 10 milliequilibrium per liter of potassium, so potassium deficiency is also there. That's why the IVRL is replaced for this. Digestive aspiration, definitive treatment is surgical treatment, that is the truncal vagotomy, enterectomy or gygestomy, gastrojejunostomy or pyloroplasty. Now second deformity of pyloric stenosis is hourglass stomach. Due to cicatricial contraction of a saddle-shaped ulcers of the lesser curvature, the stomach is almost divided into chamber. Clinical features always and almost seen in women. Periodicity is lost. Vomiting is quite common. Investigations, barium meal X-ray and OGD-scopy is perfect to investigate, to diagnose, to recognize the hourglass deformity, hourglass stomach deformity. Treatment is bile road first, gastrectomy, and third is the teapot stomach. In the teapot stomach, longitudinal shortening of the long-standing gastric ulcer at the lesser curvature will produce pylorus pulled up. Here is the end of our surgery lecture 5, perforated peptic ulcer and chronic stenosis. Thank you, students.